So what's the next step? The next step, when you have performed this non-invasive imaging, you should discuss of your patient in a multidisciplinary team based on your patient characteristics and your institutional experience. So if you don't have any diagnostic, you have to move on, and you can perform invasive imaging. During this invasive imaging, you can perform brush cytology, fluoroscopy-guided intraductal biopsy, or you can mix them. You can perform cholangioscopy or enhanced imaging, advanced pathology, and do not forget if you can perform EUS. This is very nice. You have a lot of diagnostic endoscopic tool, but you have to be cautious about the factor influencing outcome and accuracy of your test. You have to take care of the preparation of your patient when you do that kind of things, including a proper sedation. You have to have sufficient skills. The tissue handling in the endoscopic room should be very precise. Tissue handling and processing at the pathology department too, and the skills and proficiency of your pathologist. If you take care about that kind of patient, you should go again to your pathologist to discuss with them of the case. Don't forget to perform a EUS, FNA or FNB if there is no transplantation project. And then, if it's inconclusive, you can repeat invasive diagnostics. So take-home messages: cross-sectional imaging must be done without stent. I think this is a key point, more important. So patients should have a CT scan under MRI. The optimal test for the diagnosis of indeterminate biliary strictures does not exist. Specificity of most tests is almost perfect, but sensitivity lags behind. What should we do about conjugoscopy, perhaps in the future, in the first line? And do not forget about the potential of EUS, FNA or FNB if there is no transplantation project. So in diagnosis of malignant biliary stricture, more is better.
So next, we looked at echoendoscopy in biliary strictures. And there is a recent meta-analysis that is showing that it can be really beneficial to perform an echoendoscopy after a non-diagnostic ERCP with already brushing. Of course, it's higher for distal biliary strictures or when there is a mass identified, but it can be also very useful in proximal strictures, or it can be used. And in studies, it is shown that echoendoscopy and echoendoscopy with FNA changed the pre-planned surgical approach in 60%. And the sensitivity of echoendoscopy and performing an FNA is quite good also for proximal strictures. But first we will interrupt this presentation because we see that the narcose room is ready and we want to show a live case of a proximal stricture.
You see that? Yeah. We see the black spot just on the right bile duct. And I can go easily, so because the question is, should we make a dilation before put the stent? What would you do, Peter?
In case I would go for plastic stenting first, maybe we can do the discussion with the others, but I would place a plastic stent, and in that case I would dilate first. And the reason to perform plastic stenting first is because we tend to go for a two-step procedure in these patients. First we place the plastic stent, we see whether we have indeed enough regression of the cholestasis, and then as a second step we place the palliative uncovered metallic metal stents, the metal stents. Yeah. I don't know what the approach is of the others, and from you, Jean-Baptiste, in this case, would you go for metal stenting directly, or would you go for plastic stenting first? It's palliative setting.
It's palliative, yeah. I think this is a very complicated question too. But in our unit, perhaps we will put a metallic stent. None, just for the right part, we will put a metallic one.
Peter or Jean-Baptiste, when you do a metallic stent, do you give afterwards ursogol to prevent occlusion of the stent, or isn't that an issue?
So you give ursocholic acid to prevent occlusion for the stents. That's the question.
No, in Nancy we didn't do that, but if a patient is coming every 3 months or 6 months, as you know, now patient with colorectal cancer with metastasis have a very long life. I mean, so sometimes for very rare patients we put some, but not in a first intention. I don't know if you do that or in Ghent or
no, we
you should discuss of your patient in a multidisciplinary team based on your patient characteristics and your institutional experience. So if you don't have any diagnostic, you have to move on and you can perform invasive imaging. During this invasive imaging, you can perform brush cytology, fluoroscopy-guided intraductal biopsy, or you can mix them. You can perform cholangioscopy,